Okay, my friends, this is the second part of the antepartum assessment. It should correlate to the Davis text chapters 3, 4, 5, and 6. All right, so yesterday we ended with talking about the different stages of the trimesters, I guess I should say, and some of the things that moms should expect. So now we're going to start with, these are the danger signs. These are the things that we need to teach our moms that they need to be reporting if they're having a persistent issue with this, okay? Persistent vomiting, visual disturbances, swelling of the face, fingers, or sacrum, severe continuous headache, epigastric pain, muscle cramps, uterine cramping, which is consistent. Some uterine cramping is normal, but if it stays cramping, no matter what you do, if I drink and lay down and rest and all those different things, then those are things we need to report. Urinary frequency, so new urinary frequency, burning, or the opposite, oliguria, so no voiding whatsoever. Those things are things we need to report. Infection signs and symptoms, so those are still the same. Chills, temp over 99, painful urination, abdominal pain, any kind of fluid discharge, being a leak or gush of fluid, could possibly mean a rupture of membranes. So those are things that we need to think about. Vaginal bleeding and change in fetal movement or increased heart rate. So the question is, how do I know if the baby's heart rate has increased or decreased? Well, it is now available that you can rent the small Doppler machines from different places. So moms may be listening to babies' heart rates more frequently than in the past. So those are all things that we need to report. Nutrition. So these are things that overall moms should be doing while they're pregnant. They do need to increase their calorie intake, protein. They need to add a folic acid. Hopefully, if they are in childbearing age, we're already taking a folic acid. Typically, the issue is that by the time moms realize they are pregnant, that folic acid has to do with the neural tubes, so the brain and the spinal cord forming. That usually happens very early on. So usually by the time they realize that they're pregnant, they've already kind of missed the boat, so to say, on the folic acid train. So if you are in childbearing age, you should be taking a vitamin that has folic acid in it. So that is super important. You may need to take iron. That depends on what your doctor tells you. A prenatal vitamin, you can buy those over the counter any place. They are great for your hair and for your nail growth. So many people just take them in general because they're such a complete vitamin. You want to make sure that you're increasing vitamin A, C, and calcium. So we need to think about important foods to recommend. Not everyone likes, say, drinking milk, so maybe yogurts, other things where we could increase our calcium. You want to be taking in 8 to 10 glasses of fluid a day, where 4 to 6 of those should be water. So remember, sodas have caffeine, coffees have caffeine. So if you're going to be doing that, maybe keep yourself to 1 caffeine drink a day. The other fluid that you intake needs to not have caffeine in it. Okay, so poor nutrition can lead to anemia, preterm labor, obesity, and intrauterine growth restriction. All important things that we need to talk about. Okay, so again, folic acid is super important for the prevention of neural tube defects. Foods that are high in folate are your leafy vegetables, dried peas and beans, seeds, orange juice. All these things are high in folic acid. It's just easier for those people in childbearing age to go ahead and just take some folic acid in a vitamin, and that will cover everything. So you do need to take a vitamin if you are in that childbearing age range. All right, so looking at our anatomy, so these are a couple of things that we're going to start talking about, you're going to hear. So fetal membranes develop around the baby, right? Inside those membranes are the fluid. That's what the baby's going to be floating around in. So there are two layers of the fetal membrane, the amnion and the chorion. When we're talking about our umbilical artery, there are two arteries and one vein. The two arteries take the deoxygenated blood back to the placenta. The one vein carries the oxygenated blood to the baby. So that's that process. So one of the things that we look for after babies are born are what this cord is actually showing you. We're looking to make sure that there are 3 vessels in that cord. Typically, your umbilical vein is going to be huge, and your arteries are going to be small. So it's a little backwards from what you're used to when we think about adults and how that heart works and all that kind of stuff. So that's what we are looking for. Now, Wharton's jelly is that substance that covers and surrounds those vessels, and it keeps or tries to keep those vessels from being compressed. If this is the only way baby's getting blood to them, right? This is the only way I'm getting oxygen. This is the only way I'm getting that blood flow and blood return. If I rolled over on this or something happens to this cord, then I'm in a bad state of affairs, right? Things are not going to go well for me. So this Wharton's jelly is what is around those vessels to protect them. The embryonic sac is also that bag of waters. It's that amnion and chorion, that membrane that forms around baby. So this is that sac that when it breaks, that's when all that water will start leaking out. Okay, so what does it do? So this sac contains the baby and the fluid, and it keeps it helps baby to grow. Okay, so let's think about this. If baby was in there trying to grow and there was no fluid around them, then their skin, their body parts would kind of stick together, right? Because if I'm just laying inside of something for a while, it's a warm environment, that skin is going to be very sticky. So I need these membranes to help keep the skin hydrated, for one, and it allows for growth, and it allows the baby to be able to move its arms and legs. Okay, I'm going to start developing those muscles. All these things have to grow, so we really need that fluid to be in there. That fluid, that is a barrier. It helps keep the environment sterile. So why do we need baby to be in a sterile environment? Well, the vagina is in an area of the female's body where there's other things going on, right? I void down there. I have bowel movements down there. Either one of those have bacteria, right? So this membranes help to keep that baby in a sterile environment. That way I don't get any kind of bugs or bacteria, anything that could cause me harm. Okay, that amniotic sac, that fluid should be clear, and it is mostly composed of water. Every 4 hours or so, it replaces itself. So as baby gets older, as baby develops, at some point it will start some breathing exercises, and those breathing exercises will include breathing in that fluid. Baby also is going to start doing some swallowing, and baby's going to start peeing. So all these things are happening in this fluid. Now, I know that sounds really yucky, but remember, urine is sterile until it comes out of the body. So as long as this baby is in this nice enclosed area, I can breathe in this fluid, I will drink this fluid, I will void out this fluid. Okay. There's also some proteins and carbohydrates and fetal cells. There's lanugo in there. Lanugo is just the hair that babies have on them until they get a little bit older. That's just as they're starting to grow some of that adipose tissue that helps keep them warm. They'll start with having some hair on usually on their shoulders and back and arms. Vernix is just a white kind of cheesy substance that you will find on the skin. That is to help keep that skin moist and keep it from breaking down. So typically the amount of fluid that you have in there is about 1,200 ml, so 800 to 1,200 mLs. And then as baby starts to get larger, that's going to decrease and you're going to have less and less. All right, so what does the fluid do? What's that amniotic fluid do? So I talked a little bit about some of the things that it does, but here's a few more areas. So it cushions the baby, right? So if I'm, in there in mom's abdomen and say I'm in a car accident, that fluid's going to cushion me, right? If mom falls, that fluid's going to cushion me. It acts as a barrier to help baby stay safe as well. It prevents the baby from sticking to the amniotic membrane, like I talked about, or sticking to itself. It allows for fetal movement. All right, baby needs to be able to move so that my arms and legs can develop. I have to develop these muscles, right? They form. So those are the things that I need to do. If I'm not able to move one of those arms or one of those legs, that musculoskeletal system will not develop correctly. And it provides me warmth. Okay, it keeps me warm. It stays a consistent temperature. So even if mom is outside where it's cold, it's going to keep me warm much longer because it is a more of a stable thermal environment. Okay, so mom may notice that she sees some skin changes during pregnancy. Chloasma is just the increase of pigmentation on the face. So in this picture, you can see where mom kind of has some brown spotting on her face. So that can happen. It's not as common as these other two things. The linea nigra is that dark pigmented line that runs down the middle of the abdomen. You will see that more. And then, of course, you are going to see the striae gravidarum, which is stretch marks. So you will see those on the abdomen, sometimes on thighs, sometimes even on breasts, depending on how quickly the breast tissue starts to develop once mom becomes pregnant. Okay, so at 20 weeks, I'm halfway through my pregnancy. The baby should the fundal height is going to be right about at the umbilicus, so we should be measuring. Rather, it'll measure a little bit smaller than what it will later on as baby gets larger. The baby will have some hair, some lanugo and vernix. They will have very little fat though. So if you see a baby born at this gestation 20 weeks or so, baby's going to look more alien-like. And by that I mean their head is very large and their body's going to be very skinny. Okay. Baby's approximately the size of a banana. Measures about 6.5 inches from crown to rump, so from the top of the head to the bottom of the butt. That doesn't include legs. Okay. There is a short video here that you can watch to help show you what all is happening. So yesterday we spoke about risk factors, things that would make mom be considered a high-risk patient as opposed to someone who is low risk. So these are some risk factors. We're going to talk more about these in class. I'm just going to quickly go through the list now, but we'll have a better discussion about this in class, and hopefully these things will start making a little bit better sense to you. So under the age of 17 or over the age of 34, high parity, so more than 5 pregnancies mom has had. If mom becomes pregnant 3 months, 3 months since the last delivery, so I have a baby, say in January, and February, March, April, I'm pregnant again. So that makes you a high risk. If you have hypertension, if you're anemic, if you have more than one baby, if you have RH incompatibility, so we're going to talk about that. If I have a history of dystocia or previous operative delivery, also we'll talk about that. If I am shorter, so if I'm 5 feet or less, if I have malnutrition. So malnutrition will be considered those who are underweight and those that are overweight, because just because you're overweight doesn't mean you have good nutrition. If you have any kind of medical disease during pregnancy, so if you are diabetic, if you have thyroid issues, if you have hyperemesis, which is persistent vomiting, if there's any kind of clotting disorders, those will cause you to be a high-risk patient. Any infection in pregnancy, so it's called, one of the things we test for is TORCH. It's just the acronym for toxoplasmosis, other, O is other, rubella, cytomegalovirus, and herpes. If you get flu, HIV, chlamydia, and HPV, or if there is a history of family violence or lack of support. So we will discuss these a bit more in depth in class. How do we assess fetal well-being? So there are some diagnostic things that we can do, which are ultrasound, right? Those can be performed abdominally. They can be performed transvaginally. We can use a Doppler machine to listen to baby. We can do a biophysical profile, a non-stress test, a contraction stress test, or an amniocentesis. So for those patients that are very high risk, or they're looking at maybe baby has some genetic issues, those people will possibly have some percutaneous umbilical cord sampling, chronic chorionic villus sampling, a quad marker screen, or an alpha fetal protein done. Okay, so ultrasound. We'll discuss this a bit more in class because I have some different pictures that we'll talk about. Right now the craze is to go and have a 4D ultrasound done. So many times people are having much more ultrasounds than what there used to be. It used to be that you might have a preliminary ultrasound very early in the pregnancy, but usually it was at 20 weeks you would have that ultrasound. They would do an anatomy scan, make sure everything is growing appropriately, and then they would let you know the gender if you were wanting to know that. So it's more wide now that people are getting lots of ultrasounds. Okay. So usually in the first trimester, we're looking for how many babies are there. Are we seeing cardiac movement? Are there any issues with the uterine environment and what the gestational age is? Usually in the second and third trimester, we're looking at is baby viable? How is baby measuring? Are they up to their gestation age? Does their size match the amount of weeks that they should be? What's the volume of the amniotic fluid? Where is that placenta at? That's really important. We're looking for any anomalies in the uterus, or we're looking to confirm some results of amniocentesis. Now, as far as ultrasound and what we're going to tell our patients, if you call and are scheduled for a ultrasound, they're going to tell you to drink 3 to 4 glasses of water and not to pee before your sonogram. This is really important if you are in your first or early second trimester. Once that baby gets bigger, it won't matter whether or not you drink. If you call and schedule it, radiology will still tell you to drink water and not to pee. But as that baby gets bigger, it's not going to be an issue whether or not you pee or not, because they're looking at the baby and the baby's big enough to see. The idea is for those when the baby is still very small in that first and early second trimester, is that bladder will push that uterus up, and so it's easier to see. Okay. Now, if you are very, very early in your first trimester and the sonogram is being done transvaginally, they'll have you go ahead and void before. You will not need to have a full bladder for that. Then the bladder will be in the way. So just depending on what they're doing, we will make sure to do all those things. Mom will be positioned with pillow under the neck and knees. In the last trimester there, we're going to place a pillow under probably that right hip to try to displace that uterus a little bit for that supine hypotension issues that we talked about yesterday. We will, usually they'll swing that screen around so that mom can see it. If you're going to one of these places that do specialized ultrasound, they have big screens so everyone can see what's happening. You do want to make sure that there's a restroom readily available, because pressing on mom's abdomen on top of having the baby in there, she will need to use the restroom and void, possibly very frequently. Chorionic villi sampling will be done usually very, very early in the pregnancy, usually about 10 to 12 weeks. They will use a sonogram, and they will go in and take a sample of the fetal cells from that placenta, and they're doing testing, genetic testing. They will then send that off and have the cells tested for any genetic issues that may arise. This is not something that's normally done. This is done if mom or dad has a history or a family history of a genetic disease. So this is not something that's done all the time. It is not without risks. Any of these are times where you're entering that uterine environment to test, you run a risk of miscarriage. So that's one thing that mom needs to be fully aware of. And that's something, a consent will have to be signed for this. So the physician will have to discuss this with the patient. Definitely need to drink some fluid before they come. You'll need that full bladder. So if you look at this picture over here, you see here's our full bladder. Next thing down is there is a speculum in there. They open that to open the vagina area. They will stick the catheter through the cervix and up into the placenta and get those cells to test. It's hard to see, but on the top is actually that ultrasound probe, so that they're making sure they're getting into the right place. Okay, amniocentesis is another test that can be done. Usually this is done either for a genetic diagnosis if they're trying to confirm something. If so, that may happen in the first trimester. If they're doing this in a last trimester, they're looking for fetal lung maturity to see, is this baby's lungs mature enough that if they come out, they will be viable and be able to live. And sometimes they will do it for fetal well-being. So they will do this under guidance of a sonogram, an ultrasound. So they will enter or use a very large needle. It will go through mom's abdomen into the amniotic fluid around baby. They'll draw that out and then take that fluid and have it tested. We need to make sure that mom is aware that anytime you're entering into that uterine environment, that can cause to put you on into labor. So if it's done very early on, there is possibility of miscarriage. If it's done later on, there is the possibility of delivering early. Once an amnio is done, you're going to definitely need to monitor baby, especially if this is a term baby or greater than 20 weeks size baby. So we'll listen to some heart tones, we'll watch for contractions, have the patient rest. If mom is Rh negative, then she will get a dose of RhoGAM. If at any time mom starts to experience any fever, chills, leakage of fluid, or bleeding, then they're going to want them to return to the hospital, and they're going to want to rest and drink lots of fluids in the post 24 hours. If we're looking for fetal lung maturity, usually that's done if baby is less than 37 weeks. So I've seen it done a lot for people having twins. If they're wanting to or needing to deliver around 35, 36 weeks, they may go ahead and do an amniocentesis, make sure lungs are okay, and then they can go ahead and get that scheduled for birth. So this is just a picture of how this works. So they're going to use that sonogram to make sure, A, that they're not going sticking a needle through the placenta. That would be very bad. And that they don't stick the baby. So it is a rather large needle that's being used. So they're going to use that sonogram machine to make sure of all those things. They just want to get fluid in that syringe and test it from there. So these are some of the risks that come with it that we have talked about, or I have talked about in the last few slides. So miscarriage, of course, your amniotic fluid could continue to leak. There could be an injury to baby from the needle. There is a risk for infection, and there's a risk for Rh sensitization. So if mom is Rh negative and baby is Rh positive, there could be a mixing of blood, which could cause there to be a big issue with baby. And we'll talk about Rh sensitivity. Preterm labor, that's a risk factor as well. So we want to make sure that we are looking at all of these different things, and that mom is being talked to about these things prior to the amnio. Okay, non-stress test. So of these kind of prenatal pregnancy testings that we can do, this one is the least invasive, more along the lines of a abdominal ultrasound. So basically what we're doing in a non-stress test is we're putting 2 monitors on mom's belly. We're going to monitor for contractions, and we're going to monitor baby's heart rate. Usually we're going to do that over a 20-minute period, and what we're looking for is an acceleration in the heart rate. So all of these things are going to make a little bit better sense once we're able to, I can show you and we can talk through them in class. But understand that what we're doing is we're testing for fetal well-being. So the only way for us to really know how things are going inside of mom is to put these monitors on and just monitor the baby's heart rate. So we're looking for, is mom having any contractions? If she is, how does baby react to it? So what we want to see when mom has a contraction is that heart rate increasing, right? We're going to want to see that heart rate going up, because that tells us baby's got good blood flow, my oxygen levels are great, I'm a happy little baby. Okay, that's what we want to see. If we pick up some contractions and baby's heart rate is going down, then we're going to be concerned about that. So when we look at these things, we judge a non-stress test as reactive or non-reactive. So a reactive stress test is one that is good. That means baby's heart rate has some good increases, some good accelerations, and that means that all is well in my environment. Mom can go home and things should be all good until next week. We'll do that again, okay? So a non-stress test can be done at all different stages. Typically, we need a little bit older baby, just because some of our early babies, if you're 20 weeks, 21, 22, 23, 24, babies are still so little that you're not going to be able to consistently monitor them on the monitor, because once I show you, they're rather large. So if you think about baby size as opposed to the actual transducer that we're putting on mom's abdomen, if you're trying to monitor someone that's, say, 20 weeks, in that uterus is still just barely out of that pelvic area. So trying to monitor that is very difficult. Sometimes even until baby is 34, 35 weeks, we still struggle with getting a good monitor strip of any length of time on these babies. Okay, so those are some of the issues that we might have when we're trying to do a non-stress test. So usually you'll see these done officially as a non-stress test. You'll see these done as mom gets close to term or is now moving into a post-term kind of a state, okay? Typically they'll put mom, if they're doing it in the office, they may put mom in a recliner chair, or they may have her in a tilt kind of a position. We'll put gel on the belly and you put the ultrasound monitor on there, and then a toco, which actually is a the other little transducer thing that actually monitors contractions. And we will sometimes give mom a button so she can push every time she feels baby move. We watch for at least 20 minutes. If mom did the things that we asked her to do before she came, like have lunch, eat breakfast, then baby should be moving around. It should not take very long. If baby is asleep, they do sleep, and there are sleep cycles. So we may have to repeat the test. We can have mom, usually the easiest thing is to give her a glass of cold orange juice or apple juice. That little bit of sugar and the coldness of the juice kind of tends to wake baby up a bit. Okay, so looking at a reactive, what we would call a reactive non-stress test. Okay, the top line is the baby's heart rate on this picture. The bottom line is maternal contractions. Mom does not have any contractions going on. That little bit of movement in that line there is probably her talking or breathing, because those movements will pick up. The toco monitor that's on the abdomen for contractions. All it's feeling is changes in or tightening in that abdomen area. So if you think about it, if you're laying there talking, those muscles will tighten up. If you're breathing, if you're laughing, those kind of things will happen. So looking at the top of this strip, this is the baby's heart rate. You see that it's pretty steady, and then it goes up and has a nice big acceleration and comes back down. This is what you would call an absolutely perfect strip that is reactive. That means baby has nice big accelerations of the heart rate. So we're going to say that this baby has a reactive stress test, and we'll be good to go home. Okay, if it's abnormal, okay, so if I'm not having these big accelerations, the first thing I'm going to think is this baby asleep? So I'm going to do a few things, maybe give mom a snack, some juice, see if baby doesn't wake up. So there's some things that we can do before we we move further, okay? If this strip still does not look good, then we'll probably go ahead and contact our doc and see what we need to do for some further testing. Okay, contraction stress test or oxytocin challenge test. So if we are concerned that maybe baby won't tolerate labor well, we can have mom come in and do an oxytocin challenge test. To do this, mom will have to be on the monitor. We'll have to start an IV. We're going to give her some oxytocin, some Pitocin that's going to start some of those contractions so we can see how well baby handles this. You can also induce contractions by nipple stimulation. That's because the body releases that oxytocin. Oxytocin is a hormone that's readily available in the female's body. So nipple stimulation will help release that. But many times they'll just go ahead and use the IV oxytocin because then they can manage how much is being given to mom, and they can turn that off if baby starts to become distressed. Okay, so some reasons why you are not going to do this oxytocin challenge is if the baby's preterm, if there's a placenta previa, if there is hydramnios, meaning lots of fluid, if there are more than one baby, if mom has a uterine scar that's a classical incision, or if mom's membranes are ruptured. So I promise we will talk through all of these things, okay? How we're going to do it, we put these external monitors on mom's belly. We're going to record a 20-minute strip, get her IV started, do all those other things that we have to do. And then we'll start the medication, and we need to at least see 3 contractions in a 10-minute period to see what baby's going to do. So it may take a while. Some females, it takes a little bit for that Pitocin to really kick in. And a negative test means that baby did fine and we're going to possibly send you home. Okay. So when we grade these, we grade them as negative or positive, negative being a normal and positive being abnormal. So if we look at these 2 pictures here, on the right, the negative CST, you'll see fetal heart rate stays nice and normal throughout the contractions. On the bottom, those little peaks, those mountains are contractions. And so the baby in the top picture is okay. It's not great. We would prefer to see, as mom is having a contraction, we would like to see the baby's heart rate increase as well. But this is okay. Looking at the bottom part, you can see that as mom's contractions start up that hill, baby's heart rate starts coming down the hill, right? So that is a abnormal, and that means that baby is not going to tolerate labor. So this baby here on the bottom will probably get a C-section scheduled. Again, looking at an abnormal result, this is far too many contractions going on down there, far too many, and the baby looks real rough, okay, because that heart rate is decreasing every single time. So this baby will probably not even, our mom and baby will not even get to go home. They'll turn that Pitocin off and go ahead and get her a C-section before she leaves that day, and probably within the next hour or so. Okay, a BPP. So a BPP is a biophysical profile. This is something that they started doing probably about halfway through my tenure of working in labor and delivery. So basically what they're doing is they're combining different pieces. So they're going to take that non-stress test and baby gets a score. They're going to do a sonogram that's a bit more involved because they have to really look at quite a few different things. Each of these areas gets a score, and then it's a score out of 10 altogether, so you get 2 points for each area. We add them up, and as long as baby's score is at 8 to 10, then they're good to go home. If the baby's score is 0 to 2, that means we need to deliver this kid right away. That middle ground, that kind of 3 to 7 ground, depending on what's going on, how far along mom is, then we'll decide, do we need to go ahead and deliver her? Do we need to keep her and treat her and then deliver her? What do we need to do? Okay. So they're going to look for, we're going to put mom on the monitor, and we're going to look for those heart rate changes. All right, we're going to see what does that look like. Baby will get a score for that. You're going to get a score for, once the sonogram comes up, we're going to be looking for fetal movement. We're going to be looking for fetal breathing. We're going to be looking for the amount of amniotic fluid. So we're going to look for all those different things, and then, like I said, they each get a score of a 2. That totals up to a 10, and that lets us know how well is baby doing. So more specifically, this is what we're looking at when we're looking at baby. So we're looking for fetal movement on the sonogram. So we're making sure, is baby moving those arms and legs? Then we're looking for their tone. The normal tone of a baby, when I say tone, is they should be in a flexed position, okay? So they should have their arms and legs kind of flexed up in a fetal position. If baby is inside mom and they're not having any movements, and they are having more of an extended, so my arms are hanging down, that is a not normal tone, so we're going to be concerned about that. Do I see breathing movement? So by the end of that pregnancy, baby should start doing those breathing. They're practicing, okay? They're going to measure the amniotic fluid, and then we're looking at the non-stress test. Was that a good result or was that a bad result? So depending on the score of each of these 5 categories, they get either a 2 or a 0. That helps us to determine, does this baby need to be delivered now, or can this baby wait a little bit longer?